Okay, in this lecture, I will be discussing burns. So I will break up these videos into parts. So this will be on burn. So what is a burn? Burn is damage to the skin's integrity. A couple of the ways that this can happen can be with heat burns, or more so with thermal, electrical, chemical burns, cold burns, radiation, and also friction. So I'll talk a little bit about each of those. So a thermal burn is actually the most common type. And this could be from spilling hot liquid on yourself, any type of steam, or maybe a fire. You also have to think about maybe possible inhalation of that heat source. That could definitely put you at risk for respiratory issues. So electrical, this would be a current that damages skin and other structures, like the muscles and down to the bones. An iceberg effect is actually skin that doesn't look well on the surface, but the damage actually underneath that skin is much, much, much worse. Definitely for electrical as well, you have a huge risk for dysrhythmias, as you can kind of think of. If you have an electrical current that's running through, your heart is also electrical. So that can cause you at risk for dysrhythmias. There's bone fractures. Current can also break your bones. Can also get muscle damage. And also with the muscle damage, you're going to have a release of myoglobin into the blood. And this also could also be hemoglobin that can also be in there too. But we're going to talk about more about the muscle and the myoglobin. So when the muscle is damaged, those blood vessels are going to break open and it's going to release the myoglobin. And myoglobin actually clogs the kidneys, which can end up leading to acute kidney injury. Chemical burns, this could be any type of toxic substance that comes into contact with the skin. This could be like powders or gases. We also need to be mindful for watching out for any type of inhalation injury. The chemical burn that would be the worst kind and harder to treat would be an alkaline. Cold burns would be like your frostbite. It'd be also could be like called like that cryogenic burns, maybe from like any type of compressed gas like an oxygen that can give you a cold burn if when touched. Radiation burns, this would be your sunburns, and it could also be from any type of cancer treatments the patient had been receiving. Friction burns would be like any abrasion to the skin, like in a motorcycle accident, and that patient had skidded across the pavement and had road rash. That would be a friction burn. So burns severity depends on a few things. So the severity of the burn depends on how deep it is, the age. Is this person elderly or is this more of a child? The total body surface area that's burned, any past medical history, like does this person have diabetes? Does it have any other comorbidities? And then the location. So the location, like the face, the neck, the head, the torso, the perineum. So these are all respiratory complications and also infection risks. And then eschar. How much eschar is there? Where is it at? And always be thinking about the risk of compartment syndrome due to that circumstantial burn. So, and we'll talk a little bit more about that too. So the depth of the burn, So this would be your first, second, third degree, and fourth degree burns. So your first degree burn is very superficial. This would just be like your common sunburn that you would get outside. So the only area that's damaged here is your top layer of skin, which is your epidermis. This presents as red, pink in color. This is very painful, warm skin, and you have that brisk cap refill when you touch it. There's no blisters and does not leave behind any type of scarring. A second degree is your partial thickness. This is damage to the epidermis and the dermis. This is also very painful. It can cause shiny, moist, red, pink blisters. And scars could potentially be left behind. And you may need some skin grafting. Third degree burns are full thickness. So these are more serious. This damages your epidermis, your dermis, and your subcutaneous tissue. Nerves and sweat glands are destroyed. So because of that, there's typically no pain or very decreased pain that the patient will feel. The skin will not heal typically on its own, so it's going to need some skin grafting. This can also look black, yellow, and red. Hard areas would be noted as eschar, which is like that burned dead tissue. It kind of looks leathery. And because of this, that eschar can be very, very serious and cause potential complications like compartment syndrome from that circumferential burn, which can impede breathing, especially if it's on the trunk of the body or like the neck or arms, really anywhere, but typically definitely the breathing issue is if it's on the trunk. If it's on the arms or the legs, that can still turn into compartment syndrome. So typically they need to have an eschorotomy done, which is just where the surgeon makes an incision around that surrounding area to allow that eschar to not be so tight, because the eschar forms around the body like a tight band, which is constricting, and it puts you at more risk for blood clots and necrosis of further tissues. The fourth degree burn is the worst degree, of course. This is damage to all layers, your epidermis, your dermis, your subcutaneous, and your soft tissue, bone, and muscle. This is deep, full thickness burns. This is where you are going to see full black charred with eschar. So definitely going to have surgical intervention for this to have that eschorotomy done. All sensations are gone. So there's going to be no pain in the patient, and definitely would need skin grafting. So your burn location, for your respiratory area, the most concerning would be a burned area on the face, the nose, the mouth, neck, torso. You're going to want to be thinking inhalation. Any type of disability could happen if the burned injury was to the eyes, hands, or feet. You might not be able to use your hands correctly, might not be able to walk, especially if you have to have, some toes amputated or maybe some fingers, and then eyes that could cause blindness. Trouble healing. So that would just be like poor blood supply, especially if the ears and the nose are burned, because there is not a lot of they're not a lot of capillaries in the ears and nose, so they have a poor prognosis for healing due to their lack of blood supply. And then just in general, your risk for infection and disfigurement. So we talked about compartment syndrome. That puts the patient at risk for having like that tight band around the body, especially the extremities and torsos on any type of full thickness burns, which would be your 3rd and your 4th degrees. And then your other complication would be infection, especially on that peri area and your bottom due to the elimination already. So that puts you at a higher risk for infection. If you're going to have an inhalation injury, that would be damage to the respiratory system. So this would be in breathing in smoke or carbon monoxide. Huge potential risk for carbon monoxide poisoning. And if you do have carbon monoxide poisoning, you need 100% of oxygen by a non-rebreather mask. Obviously, you're going to have airway issues. And why this happens, this carbon monoxide happens, is because your hemoglobin in your blood is what carries your oxygen around your body. But when you have an inhalation injury with carbon monoxide, you breathe in that carbon monoxide, your hemoglobin actually starts to like that carbon monoxide molecules better and says, hey, I'm going to start carrying you around. So you start carrying around, the hemoglobin starts carrying the carbon monoxide around, and that's what potentially is fatal. What? A little tiny bit is fine. So the hemoglobin actually starts to like the carbon monoxide better. And so it starts carrying that around. And so that's what causes you to die quickly, because that's now being carried around. And now nothing is carrying around the oxygen. So that's why you need 100% of oxygen to get that carbon monoxide and flush that out. So how are we going to know about if we have this? We know we have an inhalation injury with carbon monoxide. How serious is it? What's the chances that it's, what's going on with it? How do we know that we have a poisoning of it? Well, we're going to drop a carbothermohemoglobin lab. And if this carbothermohemoglobin lab is greater than 15%, that is a positive result for carbon monoxide poisoning. That patient's going to start having neuro status changes, and also a classic sign would be cherry color to the lips and the skin. Some signs and symptoms of suspected inhalation injury would be burned in an enclosed structure, burns on the face and nose like we talked about, sputum, that would be that carbonaceous, which would be kind of like that black color spit or sputum. If any hair is singed around that face or nose, confusion, anxiety because I just was burned, and soot on the mouth or the nose. And those are all suspected inhalation injuries. So now we're going to move on to the phases of burn. So a little acronym would be EAR, E-A-R. So the E stands for emergent, the A stands for acute, and the R stands for rehabilitative. So E for emergent, this is the onset of the burn. So this typically happens 24 to 48 hours after the burn. So this is going to be your big risk for hypovolemic shock. So this is your time where you're going to be instilling those fluids to prevent that hypovolemic shock, typically lactated ringers. You're also going to be on the lookout for compartment syndrome and any type of respiratory distress. In your acute phase, this is when that capillary permeability has now stabilized. So your diaphoresis to the wound closure is going to be happening, and this is typically 48 to 72 hours after the burn. and until the wound heals. So your acute phase is when capillary permeability has now stabilized. We're trying to heal that wound now. And the rehabilitative, this is going to be where the burn wound area is now healed. So the main issues we need to worry about is more of that psychosocial, getting that patient back out into the real world, having them talk to people, maybe some therapy groups due to if there is any type of disfigurement, PTO2 or PT for physical therapy, maybe some occupational if maybe they lost some limbs, or lost a couple fingers. They need to know how to do activities of daily living again. And any type of cosmetic correction that might need to be done. Full thickness burns is any type of burn that's causing a major change in capillary permeability. This happens extremely fast. And this is 15% or more of the body is burned. Your sodium level decreases, causing hyponatremia. Your albumin level also decreases, and blood becomes very concentrated. And because of this is causing an increase in your hematocrit. Your hypokalemia, which we know that's causing because when that hyperkalemia is now leaking out, or your potassium, when you got burned, that potassium is now out into that interstitial fluid. So it is now out into that blood. This is also putting you also having low white blood cells and low immunoglobulins. So this is potentially causing a huge risk for infection because your lack of white blood cells and everything are very low. You also have tachycardia and low blood pressure, which is putting you at a huge risk for hypovolemic shock. So hopefully within that emergent phase, we have started those lactated ringer fluids to help stabilize that a little bit more. We also need to monitor the INO, and that's how we're going to know if our fluids if our patient is accepting the fluids and we're having proper vital signs and proper perfusion within the body by the blood pressure and the pulse. So we're going to instill a Foley catheter to monitor this, and we're also going to be testing that urine, testing that for any myoglobin or any hemoglobin within that urine. Also, we want that urine output to be at least 30 mLs per hour for proper perfusion from those kidneys. We want to have, again, with the full thickness burns that we're talking about, we want to have at least 2 IV access, and we want these to be large bore central lines. We're also going to be figuring out how much fluids we need will be based on the Parkland burn formula. So we know that since we've been studying those, that is the burn formula is 4 mLs times your total body surface area that's burned. So you'll figure that out, how much of the burned patient is. And then you're going to times that by the kilograms in weight. Albumin can be given to help with edema as well. And we want to watch out for fluid volume overload. And we also want to listen to the lungs. And if we hear any types of crackles or wetness, that's how we're going to tell if we have overloaded our patient with fluid. So again, we talked about circumferential burns with that eschar. So that causes a huge issue for compartment syndrome, which is a complication. We want to elevate those extremities above that heart level. And I had also stated that most likely would have to do an eschar, which is to cut those bands of eschar to help relieve that pressure. So you can kind of see on certain pictures, if you look those up, on eschar, and that patient actually has like pink tissue all around that surrounding cut, and that's because that tissue has expanded. Those bands aren't, that skin isn't so taut and like a hard band, so it's actually expanded, so it's actually doing what it's supposed to do. In the GI system, we want to be looking for any type of lack of perfusion. The biggest concern would be Curling's ulcers. And we would just need to be taking some antacids, also NPO. Once, bowel sounds have returned, then we could probably initiate some parenteral feedings. But right now we're going to instill that NG tube for suctioning purposes. Once bowel sounds have returned, and we can start initiating probably some TPN, most likely, because the patient isn't going to be able to most likely accept fluids within that GI system because of the ulcers, and because that the organs are not going to be functioning as properly as they once were. So we're going to just need to instill it right into the blood. So typically some PTN. So this patients are going to need some high calories, high carbs, and high protein. That's going to be a central line for nutrition, like I said. We're going to watch that blood sugar levels, because that patient could get hyperglycemic. Any respiratory issues, like I said, on the face, neck, or that is burned, we're going to be thinking of that inhalation. These people are going to most likely need to be intubated. And then in general for burns, making sure that tetanus shots are up to date. These patients will be in some type of protective isolation. We want to always assess for that temperature regulation. The room temperature needs to be at least 85 to 100 degrees. And it says for pain, IV route is best for any type of meds. And anytime we're doing any type of wound dressings, we want to pre-medicate, especially prior to debridement as well. We don't want to use any type of pillows at all, because that can cut off any type of other circulation or being applied pressure for more compartment syndrome. And we want to use any type of rolled towels. And I believe that is it.